Very good afternoon, doctors. Welcome to Neuroendoscopy Society of India monthly webinar series, episode 4. We are happy to be back with you after Diwali vacations. Wish you a very happy Diwali and happy New Year. Our topics today are endoscopic surgery for intraventricular tumors. The first topic is third ventricular tumors, taken by our international speaker. It will be followed by lateral ventricular tumors and endoport surgery for ventricular tumors. This initiative is coming to you from a digital initiative by Health and Youth Therapeutics, a joint venture with Newly Company Limited, Japan. The initiative is titled as DG Neuro. Health and You has a vision of fulfilling unmet medical needs by launching innovative first time in India products like Amnuride. We were the first one to combine amitriptyline plus mecobalamin. Amnuride 5, Amnuride 10, Amnuride 25. You can use this product for migraine and for neuropathic pain. We were the first one to come out with amitriptyline 5 milligram strength. Again, we were the first one to combine amitriptyline plus propranolol, Amnuride beta 520 ER and 1040 ER to give compliance to your patients. And we were the first one to combine amitriptyline with pregabalin sustained release form to match pharmacokinetic profile of amitriptyline, Amnuride P for moderate to severe pain. We import our mecobalamin injection for neuropathic pain from Japan. This is the only mecobalamin injection available in India, made in Japan for highest quality, so that your patient can get 100% mecobalamin and it is not converted into hydroxycobalamin. We were the first one to add a new strength of clobazam in India, 2.5 milligram strength, suggested by pediatric neurologist, pediatric neurosurgeon like you. Add clobas 2.5 milligram, 5 milligram and 10 milligram. All the three strengths are in mouth dissolving form. So now you can titrate the dose, up titrate, down titrate, or give it in BID dosage with the new addition of 2.5 milligram strength. Recently, we have launched a new concept, vitamin therapy for migraine, on the recommendation of American Academy of Neurology and American Headache Society. It contains riboflavin 200 milligram, magnesium 200 milligram, and CoQ10, brentamine, vitamin therapy for migraine. This webinar and all the other webinars, almost 40 plus neurosurgery webinars that we have conducted in last 3 months, are available on our channel on YouTube. The channel name is DG Neuro, and you can just type DG Neuro and you will get to a host of resource available on neurosurgery, 40 plus neurosurgery webinars. And this webinar will be then uploaded tomorrow by us and will be available on this channel. So please subscribe to our channel DG Neuro for updation of webinars and new resources. Thank you very much for this time. Now I have great pleasure in introducing our today's speaker and coordinator, the brainchild of this webinar is of Dr. Professor Suresh Sankhla. He is a consultant neurosurgeon from Mumbai, India, president of Neuroendoscopic Society of India, past president of Indian Society of Paediatric Neurosurgery, past president of Indian Society of Neuro-Oncology, past president of Skull-Based Surgery Society of India, past president of Bombay Neurosciences Association of India. He is also a founder editor journal of neurosurgery. He has contributed to more than 123 research articles, papers in journals. He has edited book articles of numbering 24, and he has 2 books edited to his credit. So I have great pleasure in introducing Dr. Suresh Sankhla to you, and he will be coordinated and further assisted by another luminary of neurosurgery in India, Professor Ashish Pathak, currently Director of Neurosurgery, Fortis Hospital, Mohali, Punjab, Chandigarh, former Professor of Neurosurgery, PGI, Chandigarh, former Consultant Pediatric Neurosurgeon, NHS UK, Sheffield, former Lead Vascular, Pituitary and Skull-Based Neurosurgery, NHS UK, Kingston, past President of Cerebrovascular Society of India, Honorary Secretary, current Honorary Secretary of Neuroendoscopy Society of India, former EC member of Indian Society of Paediatric Neurosurgery and Neuro-Oncology. So now I hand over the session to Professor Ashish Pathak. Sir, please take it over from here. Thank you.
Thank you, Mr. Naik. It's a pleasure for me to again be back here with the series of webinars that we are conducting. And I give the full credit to Dr. Suresh Sankhla, who has been the brainchild behind this. And I thoroughly enjoyed participating in conducting these seminars and organizing it. Today, we have a great talk, basically based on the lesions in the ventricle. So I invite all the members of the Neuroendoscopy Society of India and the other participants who have joined this to enjoy this show today and enjoy the talk. We have got three illustrious speakers. One is Professor Sergey Gorelyshev, who is going to talk on the third ventricular tumors. He's the first speaker. This will be followed by Dr. Awadesh Kumar Jaiswal, who is Professor of Neurosurgery at Sanjay Gandhi Institute of Medical Sciences, Lucknow. And then, of course, Professor Suresh Sankhla is going to again talk of Endoport surgery for ventricular tumors. They will be respectively introduced before their talk, so I'm not going into any details of their CV. We have got again an eminent panelist today, and the list consists of Professor Chandrasekhar Eknath Devpujari, who is a well-known person in India. He practically doesn't need an introduction, and I was really amazed when he sent a very humble, short CV of his, where it just says Professor and Head of Neurosurgery, Chair WFNS Neuroendoscopic Committee, past President of the NSCI Neuroendoscopy Society. This shows his humility because he never wanted to mention the other big things that he already had been chairing and holding in the past, which includes being the President of the Neuroendoscopy Society of India, being the past President of the International Society of Paediatric Neurosurgery, the NSI, the Neurological Surgery of India, Neurosurgery Society of Neurological Surgery Society of India, the Skull-Based Surgery Society of India, the Neuro-Oncologist Society of India, and the Cerebrovascular Society of India. So he had been all throughout in various positions, at the helm of various positions in the country. And of course, he is one who introduced or invented a new model for the trainees in training of neuroendoscopy, and that's really well acclaimed. I have also pleasure in introducing a dynamic, multifaceted young neurosurgeon, Professor Rajesh Chhabra, who is professor in the Department of Neurosurgery at Postgraduate Institute of Medical Education and Research, Chandigarh. He has been a very dynamic person, whether it's field of cerebrovascular surgery, minimally invasive spine surgery, neuroendoscopy surgery, neuro-oncology, neuronavigation. He has been trained at various places, including Electa Stockholm for gamma knife radiosurgery, visiting professor in Roswell Park Cancer Institute, Department of Neurosurgery, Buffalo, visiting fellow at Albert Einstein Cancer Center and Albert Einstein College of Medicine of Yeshiva University, New York. He has more than 300 endoscopic surgeries to his credit, apart from a huge number of vascular and other procedures that he has done. He has delivered more than 70 lectures in various conferences and has 90 publications, including 6 research projects. So you can see he is really, really very active and dynamic. Nonetheless, there is Professor Vijay Parihar, who is a dedicated neuroendoscopic in his field. He is in the Department of Neurosurgery at Netaji Subhash Chandra Bose Medical College at Jabalpur, which is considered as one of the center of excellence of neuroendoscopy in this country. And with 18 years experience in the field of neurosurgery, he has been instrumental, along with Professor Yadav, to be holding the various courses of neuroendoscopy, which they run at a very nominal cost, I would say. He has been an international guest faculty in the third scientific meeting of North American Spine Society, International Society of Minimal Intervention in Spine Surgery. And he is also a guest faculty in courses conducting in cadaveric workshop and international field to joint meetings of the 5th Asian MISST and North American Spine NASS in Manila. With this introduction, I now sort of hand over the whole thing to Dr. Sankhla to start the webinar.
Thanks, Ashish, for introducing the panel and starting the program. I would like to introduce the first speaker, our guest international speaker, Professor Sergey Gorelyshev. He is from Moscow and he is a pediatric and endoscopic neurosurgeon. He is very popular as a faculty and an education program and is well known all over the world for his education and teaching activities. Currently, he is the head of Department of Pediatric Neurosurgery at the National Center for Neurosurgery, Moscow. He is also head Pediatric Neurosurgery, the Russian Academy of Postgraduate Education, and vice president of Russian Association of Neurosurgeons. He is also board member of Pediatric Neurosurgery section of ENS, chairman education committee of IFNE, and active education program member of ISPN. He has also been past president and founder of Russian Society for PNS, the Pediatric Neurosurgeons. Above all, he is a good friend to most of our Indian neurosurgeons, and he loves to come to India and do the education programs whenever he gets an opportunity. So with this introduction, it is my great pleasure to invite Professor Gorelyshev to give this lecture. Sergey?
Thank you so much. Thank you so much for this friendly introduction. And really, I have a lot of positions, but the most important factor that I have a lot of friends in India, and I am very grateful for you for invitation to take part in the webinar of your society. So I'm going to share my experience with you concerning the endoscopic surgery of third ventricle tumors. I work in the huge organization. This organization is named the Russian Neurosurgical Center for Neurosurgery. It is fully devoted only to the neurosurgery. And that's why we have a lot of microsurgery and endoscopic surgery. So, so I have the possibility to compare these two methods and really not to choose one of them, but to combine these two methods. I mean microsurgery and endoscopic assistance, endoscopic surgery in my everyday work. So, and now I have the opportunity to share my experience, my ideas with you. What are the most common tumors of the third ventricle in children? So these are the gliomas of the third ventricle. So you know that there are a lot of chiasmal gliomas, chiasmal and hypothalamic gliomas in children. And one of the group of these chiasmal gliomas, or the gliomas of the visual pathways, are situated in the third ventricle, and thus may be removed both from the transcallosal approach or the basal approaches, or with the help of the endoscopical technologies. So another tumor, so in this way, it may be radically removed. Of course, we have to pay attention to the possible damage to the hypothalamic region, and we should highly avoid any damage in this area. But nevertheless, in some cases, it is possible to perform the gross total removal. So, and the endoscope greatly help us in this. So another tumor are the craniopharyngiomas of the third ventricle. And here also we differentiate several types. the endocellular, supracellular, and craniopharyngiomas of the third ventricle, or intra-extraventricular. These are the tumors which primarily grow in the third ventricle and have the origin near the ventricle floor. That's why the same, we may use different microsurgical approaches or the combination with the endoscopic procedures. So, and the third very common tumor, this is the choroid plexus papillomas, which are the favorite tumors of any pediatric neurosurgeons because they may be safely and radically removed in any child. But this procedure also may be very dangerous, and the endoscopic assistance may highly diminish this damage and help a neurosurgeon to perform it safely. So there are a lot of surgical approaches were elaborated in order to reach to the tumor of the third ventricle, and all of these approaches are showed on this picture. Today we are interested in the tumors of the anterior part of the third ventricle, and thus we should analyze the anterior transcallosal approach and the subfrontal translaminar terminalis or opticocarotid approach to the third ventricle. There is a special lecture for the transsphenoidal approach. I would not stop at this approach, and the occipital approaches to the pineal region of the third ventricle. I'm sure that these are quite different items for discussion. So that's why we are going to speak about the endoscope-assisted microsurgery, first of all. So, and I want to show that these procedures are being performed in the air environment. On the contrary, with the well-known water environment, when we speak about the ETV or other intraventricular procedures for the treatment of hydrocephalus. So these procedures are being performed in the air environment. And so for this, we use the microscope, the special assistant endoscope, and conventional micro instruments. On the other hand, we can use the keyhole neurosurgery, which is performed with the assistant endoscope and special para-endoscopic instruments in order to reach the hidden parts of the tumor of the third ventricle. So, and at last, we can use the two working canal endoscope like Lotter and endoscopic instruments. So the main ideas are to look around the corner, to look through a keyhole, and at last to do something there. So for this purpose, we use the special instruments, the special endoscopes, which differ from the well-known designed for the ventricular endoscopy. So this endoscope is an instrument with the angled camera, with a special device, which is called the clear vision. This is the special tube for the washing, for the clearing of the visual field, because as I have told, it is performed in the air environment and may be dusted with the blood, with water, so it should be washed from time to time. And of course, the main advantage of such procedures are the angled optics, which permit, as I have told you, to explore the hidden parts of the operating field. Okay, so this is the equipment of the operating room for the endoscope-assisted microsurgery. We should have at least two monitors, one for the endoscope view and another for the microscope view. So we can use the holding system, and you see this is this is the tube of microscope, and this is the tube of endoscope. So now what we can, for what purposes we can use the endoscopic assistance? First of all, for the basal approaches. So as you know, we can use the subfrontal approach to reach the lower parts of the third ventricle. So for this purpose, we perform the approach with the operating microscope, but then we insert the endoscope into operating field in order to look through the optico-carotid triangle or through the lamina terminalis into the cavity of the third ventricle. So, and on this video, you can see the chiasma, and you see this is the space under the chiasma inside the inferior parts of the third ventricle. Here you see the remnants of the tumor, the calcifications, the part of a capsula, which could not be seen with the help of operating microscope. So another idea is to, another idea is to look through the optico-carotid triangle. Here you see the carotid to the right and chiasma to the left, shifted by the spatula. And you see the remnants of the tumor hidden under the chiasma. So we can even introduce the endoscope between the carotid and the chiasma and see the remnants of the tumor in the third ventricle. You see, this is the gray substance. This gray substance is the, yes, this is the remnants of the tumor. And now we know where is it, and we can remove it either with the help of the operating microscope. So, and this is the final step, the arachnoidea. After the tumor removal, we have performed the gross total removal with the help of endoscopic assistance endoscope. Okay, so the next application is the supraorbital keyhole approach. Axel Pernetsky was, to my mind, one of the first investigators who described the keyhole approaches in neurosurgery, and this is the pictures from his famous book. But on the bottom photos, this is our own experience. So we perform the approach through the eyebrow, and pay attention for the dimensions. 3 centimeters. This is the size of the skin incision. This is the size of the bone incision, and this is the size of a dura incision. So thus we perform the subfrontal approach with perhaps with one spatula with the microscope, but then we use the endoscope. We take away the microscope. We insert the endoscope into the angle of the operating field in one of the parts of the operating field. That's why we need the angled camera in order not to close the operating field. So, and now we can use the angled instruments and remove the tumor from the third ventricle, from the lamina terminalis, from the optico-carotid triangle. Here you see the angled optics and the bottom of the third ventricle. And now you can see even the lamina mammillary bodies. You see 2 mammillary bodies were shown inside the third ventricle. And this is the membrane Lillenquist. So you see all the parts of the tumor were removed from the third ventricle. So, and this is the cosmetical results, which to my mind are rather favorable. You can see no signs of the approach. Now I have spoken about craniopharyngiomas, but now we can use the same approach for the removal of the chiasmal gliomas. Of course, we shall remove it partly, because the chiasmal gliomas originate from the visual pathways, and the main task of a neurosurgeon is the reduction of a tumor size, but not the gross total removal, of course. So, and to take the biopsy in order to facilitate the following chemotherapy. So, and you see, this is the basal approach. And this is the very small bone incision, the bone flap. And this is the size. And now you see that we managed to remove the inner part of this tumor. And as we know, the visual pathways are situated on the surface of the tumor. And the inner part of the tumor, inner part of this nodule, is pure tumor tissue, and we can safely reduce the size of the tumor, preserving the visual functions, and then to perform the chemotherapy due to the well-known protocols, for example, CIOP 2008 and other protocols. So again, this is the cosmetical result. So we have spoken about the basal approaches and how the endoscopic assistance may help us to perform the basal approaches for the third ventricle. Now we shall speak about my favorite approach, the transcallosal approach, which is to my mind the best approach to the third ventricle. And now you can compare what we can see through the microscope and what we can see with the help of endoscope. This video demonstrates the microsurgical view, the view through the microscope during the transcallosal approach. You see, of course, the majority of neurosurgeons and me as well, we perform this approach with the help of operating microscope. For many years, we were very happy with a very good view to the interhemispheric space, to the interhemispheric compartments, to the vessels, to the arachnoid space. But now let us compare with the endoscopic view. And when we started to use the endoscope assistance in order to reach the tumor of the third ventricle, we have realized that from one hand, we can use the very small approaches. On the other hand, compare the visibility of all the structures. So we can easily see the gyrus triangularis. You see, this is the very large operating field. This is very well seen, the pericallosal artery with all its tiny branches. And the main idea is to shift the pericallosal arteries aside in order not to damage the small feeding arteries. So, and you see, this is the two pericallosal arteries, and this white matter, this is the surface of the corpus callosum. So you see how nicely it is seen and with all the details. Now we can even penetrate the corpus callosum with the endoscope in order to perform the investigation of this area before using the microscope. So this is the cavity of the lateral ventricle, and this is a tumor bulging into the lateral ventricle through foramen Monro from the third ventricle. You see how nice it is seen? And then we can use either microscope or perhaps endoscope, which I will speak later. So let us pay attention to the geometry of the transcallosal approach. So you see, this is the bone and skin incision. This is the fenestration of the corpus callosum in the most anterior part, which is free from the any neurological sequelae. And this is the most so this part of the tumor can be removed with the operating microscope, but this part of the tumor is hidden from the view of the operating microscope, but it can be reached with the endoscope assistant device. So let us see how it may be performed in our practice. Of course, this huge tumor was removed with the help of the operating microscope. But the most hidden part inside the third ventricle, the most anterior part of the tumor, could not be reached with the operating microscope. And you see this white matter in the upper part of the of this video. This is the anterior edge of foramen Monro, and we are removing the tumor with the help of the angled instruments from this very very secret part of the third ventricle, from the most anterior part, which is very difficult to reach with the microscope. So, and the result, the near to gross total removal of such a huge tumor. Another situation where the endoscopic assistance may help us, when we perform the removal of the craniopharyngioma of the third ventricle, we can look to the most posterior part of the third ventricle, and this is aqueductus cerebri. You see, this is a very nice picture, and we can revise this part of the third ventricle, be sure that there are no remnants of the tumor in this part. So, and just on the contrary, this is the view to the basilar artery and its branches in the most anterior part of the operating field. So we are looking from above. So of course, this is the situation when the tumor have already destroyed the floor of the third ventricle, and after its removal, we have to check for any remnants of the capsula in this very anterior part of the third ventricle, and it is clearly seen. So, the third situation is the choroid plexus papilloma. You see, this is the papilloma in the third ventricle. Again, we can explore this region, firstly, with the help of the endoscope. Now we are penetrating the corpus callosum. We see the foramen Monro, the choroid plexus, which is situated in the foramen Monro. And now we can easily go with the endoscope inside the third ventricle, and we see that the floor is not infiltrated by the tumor. We see the choroid plexus papilloma just in the posterior part of the third ventricle. Now we know the relations of this tumor to the all parts of the third ventricle, and we can safely remove it. So I have spoken about the endoscope assistance, but of course we can use the endoscopic techniques without a microscope. And now we shall speak about the pure endoscopy. And in the majority of cases, it may be used for the cystic craniopharyngiomas. So pay attention that this is a very complicated situation. This is the craniopharyngioma with a large amount of cysts. To my mind, there were about 7 cysts. And there were a lot of calcifications, and the patient was in a rather grave condition. So we were afraid that the open surgery would be very hard for this patient, and decided to use the endoscopic techniques in order to connect, in order to make the fenestrations, the connections between all these cysts, and to connect these cysts with the ventricle cavity, and to perform the aspiration of all the contents of these cysts, to reduce their size, and then to prepare this patient for the radiotherapy. Okay, so you see, we use the special needle. This special needle is included in any standard set of the Karl Storz instruments for the endoscope assistant. So this was the contents of some of these cysts. You know that we use different instruments in order to make the fenestrations of these cysts. But the very important moment, which I have to pay your attention to, that during the surgery, we used both aspiration and irrigation. So you see the contents of these cysts may be rather toxic to the brain. So we try to aspirate its contents, but we work in the water condition. We worked in the closed cranial cavity. That's why we have to strictly keep the balance between the irrigation and aspiration. This is a very specific procedure, because if if the aspiration will be performed at a more amount than water supply, so we can obtain the reduction of the intracranial pressure with very heavy sequelae. So pay attention if you will use the aspiration and irrigation in order to check their balance. The end of the surgery was the insertion of the catheter through all these cavities and connecting it with the ventricular cavity. So we have performed our task, and this patient was treated in this way, and then the radiotherapy was performed with a good result. Now about the next part, the usage of the ultrasound aspirator with endoscope instruments. So for this purpose, we should use only one ultrasound aspirator and one model of endoscope. This is not the advertisement of a special companies, but there are only two compatible devices: the GAB endoscope from the Karl Storz and the ultrasound aspirator from Zöring. So we have to assemble these two devices, and it is really very large and a bit heavy, and really it looks like as a Kalashnikov. So it is a bit heavy and large, but we may easily use it for the removal of the cysts, of the tumors inside the third ventricle. So the next thing which is necessary, the water pump for irrigation, then the bipolar forceps, and now we have come to the surgery itself, and the very important moment, which I have already told you, that we have to every moment we have to check the balance between the irrigation and suction. But we have a lot of advantages of this method, because the irrigation is performed from the water pump through the canal of endoscope. It may be performed at a high pressure, and the suction through the ultrasound aspirator. That's why any hemorrhage will surely appear during the tumor removal, while the destruction of the tumor tissue will be washed and come inside the ultrasound aspirator. So we shall have the clear view even in a case of bleeding. So let us look how it may be performed on the video. So this is the endoscopic removal of a cystic tumor of the third ventricle. This is the foramen Monro. This is the ultrasound aspirator. And I'd like to say that you have not to do the shaving movements with the endoscope as we perform when we use the microscope. You should insert the ultrasound aspirator and wait for a while. So you see that it will destroy the tissue and it will be removed in this way. Now you see the empty cavity of the third ventricle and the cerebral aqueductus on the bottom of the operating cavity. So to conclude, the endoscopic assistance in microsurgical removal of suprasellar craniopharyngiomas, of the chiasmal gliomas, of the choroid plexus papillomas may greatly improve the quality of vision, the illumination of visual field, and makes possible resection of the hidden parts of the operating field. So it both improves the radicality and safety of surgery. Thank you so much.
Thank you, Sergey, for the wonderful demonstration of the technique and the details of the third ventricular surgery using the endoscope as an assistance as well as pure endoscopic surgery. Thank you very much. We would invite the panelists to really come for the discussion. But before they come, I would like to ask you one or two questions. One question is that whenever you use the endoscope, maybe for the pure endoscopic surgery, do you fix the endoscope or it remains in somebody's hand and you keep moving, which way you go? How can you describe it, please?
Yes, thank you. It's a very good question. It is really important detail. As for me, when I use the endoscope, for example, for the ETV, I use it freehand technique. Because you see, this procedure is very fast. It takes about 5 or 10 minutes, and it is performed at the different levels. So I know many surgeons who fix the endoscope and perform, for example, ETV with the fixed endoscope. But for me, it's much more convenient to move the endoscope because in any moment it is at different depth. So for me, it's much more convenient not to fix it. But when we use the endoscope assistance, when we perform the removal of a tumor for an hour, for 2 hours, for a long time, and for on one hand, so you will be very tired to keep the endoscope in your hand. But on the other side, you have to use your both hands for the microsurgical manipulations. So you fix the endoscope and you have both hands. In one hand, you may keep the suction tube, and in other scissors or forceps. So both your hands are free for the surgical procedures. So in this case, I prefer to fix the endoscope with the mechanical or perhaps with the pneumatic device. But I'd like to say that we have the mechanical fixation because the pneumatic one, to my mind, play the same role, but much more expensive.
Okay. Fine. Thank you very much. Dr. Dept Pujari?
Well, I think it was a very nice disposition of what can be done with endoscopic and endoscope-assisted surgery for third ventricular tumors. I had only a couple of questions. One was that you have shown very nicely how endoscope can supplement the anterior part of the tumor removal during the microscopic surgery for third ventricular tumor. We like to do it with a subsequent procedure or with a transsphenoidal procedure, or have you ever considered doing a combined surgery for the anterior component of the third ventricular tumor is probably much more easier removed by inferior approach or endonasal approach?
Mm.
And
Okay, yeah, thank you. This is also a good question because so my lecture was devoted to the third ventricle tumors.
Yes.
So I have another presentation when I show how to use the endoscopic assistance for the removal of the skull-based tumors. So, and this is, I think that there is no alternative for the transcallosal approach or for the basal approaches, for the microsurgical approaches, for the pure third ventricle tumors. I am agree with you that there is a possibility to use the extended anterior approach, I mean transnasal extended anterior approach for the supracellular space, and thus to remove these kind of tumors. But as for me, I prefer to use the open surgery for the supracellular craniopharyngiomas, for example. Of course, if we have the supracellular tumors, surely we shall use the transnasal endoscopic techniques. But even in this case, there are rare situations, but sometimes, for example, when a patient was treated several times by the open surgery, it had the supracellular tumor, and then the tumor penetrate the cellular and the skull base, and our colleagues, and we have a special group for the transnasal surgery in our institute who are fully devoted to this kind of treatment. So, and they asked me, okay, Serge, perhaps we shall try the transnasal approach. And for me, it may be a bit tricky because we can face with CSF leakage, because all the subarachnoid spaces are open from the subfrontal space, and now we perform the hole through the cellar, so we can obtain the CSF leakage. In this case, I can use again the endoscopic assistance through the subfrontal approach, but with the angled optics turned down 30 or 45 degrees. So here I showed the upward optics, but we can use downward optics, and thus we can easily look inside the cellar tooth, inside the cellar. So it may be another route for the endocellular lesions. But I'm quite agree with you because, of course, this is the transnasal surgery is in many cases is preferable.
just one more question about handling of the CSF pathways. How frequently do you do septostomy, and how frequently do you leave ventricular drainage EVD at the end of your procedures?
It depends. It depends on the situation, of course. So after removal of the third ventricle tumors, I mean microsurgical removals, both gliomas or craniopharyngiomas. So I perform the microsurgical septostomy. So for the chance, I don't know why, but why no? In case of a recurrence of a tumor and so on. So if we perform the purely endoscopic removal of the cystic craniopharyngiomas, for example, so in this case, it is very hard to perform the ETV because the tumor originating from the floor of the third ventricle, and it is covered by the remnants of the tumor.
No, I was talking about EVD. When do you take?
You're talking about EVD? Yes, sometimes it again depends, but in a very rare situations, because in the majority of cases we at least open the passage of the passage of the CSF through the third ventricle, and we are not afraid of the obstructive hydrocephalus. So in rare cases, but nevertheless, we perform the EVD in the cases of tumors of the lateral ventricles or in the posterior fossa tumors, but rarely in the third ventricle tumors, to my mind.
Rajesh, over to you.
Yeah, yes, perhaps yes. Yes, no, on the other way, if we are not going to radically to perform the gross total removal, if we, for example, have a glial tumor which infiltrate the walls of the third ventricle, if we cannot open the CSF spaces, so of course we shall, and we prepare this patient for the radiotherapy, then of course we shall perform what we shall perform. ETV is not so easy to perform in the tumors of the third ventricle, so that's why we have to perform the shunting procedure. So.
Dr. Rajesh, yeah.
Yeah, Dr. Gorelyshev, I mean, it was a nice lecture. Basically, my concern is regarding instruments. I mean, in endoscopy, you can see, but certain times it's, or rather, I think it's most of the time, my instruments are not reaching there. So how you compensate for that part? You know, it's visible, tumor is visible, but you don't have, you know, the instrument properly designed to reach in that area, especially in pure endoscopy. I mean, do you find any, I mean, special instrument or any concern about that? Any constraint about in the reaching the tumor part? Visualization is, I mean, sometimes it's visualized, but you are not able to reach there. You're not able to properly handle that tumor in that area. So that is my concern when I operate. I mean, that is my question.
Yes, thank you. So there are different ways concerning the usage of instruments. So the one way is to use the basic, not the basic, but the instruments of designed for microsurgery. So the angled instruments are included in any catalog of any well-known companies such as Esculap and others. So you can find there the angled micro instruments designed for the microsurgery. So there are a lot of such models. So this is for the situations when we use the endoscope and use the instruments in the para-endoscopic space, so aside the endoscope. Another situation, when we use the keyhole surgery, this is the very narrow operating canal. So, and in this case, we use the special set of, I haven't shown in this lecture, perhaps you know that there are the instruments like the stylus. So it has no expandable branches, you see? So it has the handle and like the instruments for the endoscope, but it is not so tiny, it's a bit larger. And it is designed, I think, especially for some deep ones. So, and these instruments you use with the handle inside, with no expandable branches, only with instruments on the tip of these small scissors or small forceps. And that's why you may insert them alongside the endoscope. And the third way is to use the routine endoscopic instruments in the situation when we use the endoscope in the air condition. Or again, I haven't shown it because I had no examples of the third ventricle manipulation. But for example, in some cases of germ cell tumor biopsy in the chiasmal space, we again perform the subfrontal, very small subfrontal approach, very tiny, and then we use the routine LOTA, for example, but in the air space, in the air condition, and we use the bimanual technique, for example, the forceps and coagulation. So, but we work in the air condition. So we can even introduce the small tube to aspirate the blood or the CSF. So this is the third situation when we can use quite different instruments, but for the same purpose.
Rajesh, I think probably it is, I don't know if it is clear, but I think the new adult LOTA scope or the DEC scope, they have an extra channel. So you can actually do bimanual dissection. And therefore many things which you cannot do with a regular GAB or the small endoscopes, you can do much more than that with these. I think DEC was specially prepared for colloid cysts and ventricular tumors. And the other thing what he's saying is for endoscope-assisted surgery, you must have seen Pernesky shaft instruments, which can be very, I mean, they can virtually be put parallel to the scope without too much space occupation and open only at the tip rather than the whole shaft.
Yes,
Yeah, thank you. We are not going to stop at this level. We are going to develop these techniques. Thank you for these advices. Of course, we shall go further, and I'm going that we can share our future experience with you.
Is Dr. Parihar around? Dr. Parihar, Vijay Parihar. Okay, any question, Ashish?
You have to mute yourself, Vijay.
I think Vijay is there. Vijay,
Okay.
would you like to ask something?
Yeah. Very nice presentation, Professor. Do you have any experience with the using exoscope also during your surgery?
Yeah, again, very good question. No, unfortunately, no. I have tried it. I have tried the exoscope in the experimental situation, even during some surgery, but for me it was not comfortable. You see, I know many neurosurgeons who use it very successfully, but for me it was not comfortable. If we use this, for me, the same procedures may be performed with the traditional microscope, because it is also is situated over the operating field. So either we use endoscope, either we use microscope in order to look inside the brain from the outer space. Either we use endoscope in order to look at the operating field from inside. But nevertheless, perhaps you can find another expert which would show you the advantages of this method.
Vijay, you can probably tell us, do you use the exoscope regularly for ventricular surgery?
Yeah. We are using the exoscope regularly, quite regularly for ventricular surgery, also for the skull-based surgery.
With the port. Because I think the biggest advantage of using an endoscope as opposed to exoscope is that you can literally, you do your retraction with your scope. Not only you see it with the scope, you do your retraction with the scope and suction itself. While for exoscope surgery, you will require to have a port or retractors in.
Right.
So you use port most of the time, correct?
Yeah, we are using port. That is tubular retractor, which Professor Yadav is.
Correct. Great. Okay, I think in the interest of time, we stop the discussion here and move on to the next lecture. Thank you very much, Serge, once again for this great presentation. Good discussion. Thank you very much.
To stay with us, Serge, for the other two talks so that we can listen to your comments also.
From time to time. Yes. Ashish, please take over.
I will stay with you, but I apologize. Perhaps in the end of your session, I have to escape because it will be too dark in Russia. So, but I will stay with you as far as possible. Thank you.
No problem. Thanks.
Right now, after this talk, which was really mesmerizing, I have the pleasure to introduce Dr. Awadesh Kumar Jaiswal, Professor of Neurosurgery at Sanjay Gandhi Institute of Medical Sciences, Lucknow. Awadesh has been a keen neurosurgeon who has been involved with endoscopic surgery. He has received gold medals, book prizes, certificates, honors, and scholarships during his medical training. Shows that he was a devout uh, student in his career. He's got membership of various societies, which includes the prestigious Neurological Society of India, the Asian Conference of Neurological Surgeons, American Association of Neurological Surgeons, Association of Spine Surgeons of India, Asian Association Society of Stereotactic and Functional Neurosurgery, and of course the Neuroendoscopy Society of India. He has his area of interest is neuroendoscopy, and he has published uh, articles in 104 journals, chapters in books, and of course, he has got innumerable presentation in various conferences. So without wasting much time, it's my pleasure to invite Professor Jaiswal to give his talk today on lateral ventricular tumors. Dr. Jaiswal, please.
Good evening, everybody. And I'm thankful to Dr. Suresh and Dr. Pathak and the society for giving this opportunity to present my experience on this interesting subject. Is my screen visible?
Yeah.
Yeah, okay. So I'll be talking about endoscopic keyhole surgery for lateral ventricular tumors. Lateral ventricular tumors form less than 1% of all brain tumors, and the most common presentation is raised intracranial pressure, and surgery is the mainstay of treatment. Basically, there are two approaches, either microscopic or endoscopic. Microscopic usually by transclusal or transcortical, and endoscopic approaches most of the time transcortical. That includes three types of approaches. I have written two, but there are three. One is pure endoscopy by channeloscopes, and other one is endoport, will be talked about Professor Sankhla after my presentation. And I will be talking about endoscope controlled approach for lateral ventricular tumors. So what are the challenges with the lateral ventricular tumor? Because the tumors are located in the deep and the proximity of vital structures, so these are technically demanding. And microscope provides poor visualization because a lot of light is wasted when when the light reaches to the target area. It becomes very less, and there is limited view is seen by microscope. Here, endoscope gives added advantage in form of excellent visualization and provides panoramic view. As you can see in this picture, there is very narrow view by microscope, and with endoscope you can see panoramic view, and the quality of visualization is excellent. So just to give examples, this 13-year male presented with raised intracranial pressure, and you can see lateral ventricular tumor present in the anterior part. This is a CT picture. Patient could not be investigated by MRI because he was having severe raised pressure and came on holiday and MRI was not working. This patient was planned for keyhole craniotomy and tumor excision by endoscopic transcortical approach. So patient was kept on supine position with head slightly up in straight position, and we don't use any head fixation or any navigation usually for these procedures. We put a ECG electrode over the nasion, you can see here, which guides us when the patient is about the midline, when the patient is under drape. So you can palpate it and determine where is the midline if you are somewhere forgotten. Now you can see the scalp markings. We mark the sagittal suture, midline, as well as the coronal suture. And a burhole marking is made about 2.5 to 2.5 centimeter anterior to the coronal suture in the mid-papillary line, as you can see here. And this is the proposed margin of the craniotomy. And this is a curvilinear incision, which is the scalp incision. Earlier, I used to make a linear incision, but which used to produce wound bulge sometimes, and we don't get pericranium much. So this small flap curvilinear incision gives a small flap through which we can get some pericranium and help during closure. You can see here, this is the site of burr hole, and this is the craniotomy size, and this is the scalp incision marking. Now the patient has been draped. You can see this is the marking of the scalp incision. Now the scalp flap has been raised. You can see here. I prefer to use a stitch retractor rather than putting a fixed retractor. The bone is exposed. You can see coronal suture here. And after this, this is the we take a monopolar and make the marking of the burr hole area and the proposed craniotomy size. This is about 2.5 centimeter craniotomy size. We have made the marking with the monopolar. This is the coronal suture. Now burr hole has been made here. You can see here. And now the craniotomy has also been made with the craniotome. This is the size of the bone flap, about 2 centimeter. This is keyhole craniotomy. And after this durotomy has been done, you can see here, this is the brain, underlying brain. This now the pia is coagulated, and then an incision, small incision is made over it. And I have a trocar and cannula of an old endoscope, which is thick bore. And we can see here it has been inserted till it reaches to the ventricle. And after that, I do maneuver like this, just to widen the tract. And this tract, after it gets widened, we need not to do any cardiectomy. It is enough widened so that endoscope can go inside, and language instrument can also be go inside. This is the OR setup. You can see here, I'm sitting here. Assistant sits left to me, and I make the assistant very comfortable because the assistant role is very important in this procedure. You can see here the assistant hold the scope with both hands, and this is a screen. You can see this closer view. These two are my hand. This is left and right hand, and this is the assistant hand. One hand he holds the scope, another hand over the tip of the scope. This is a schematic diagram to show how the instruments are placed. The endoscope is held in the upper part, section in the left hand by surgeon, and instrument or bipolar dissector in the right hand. This is a freehand technique, and no retractor whatsoever is used in this procedure. These are the various simple instruments which are used in this procedure. The endoscope, telescope, bipolar, suction, biopsy forceps, dissecting, penfield dissector, and long and short bayoneted fine forceps. This is the operative video of the same patient. You can see here we have breathed inside the visualized tumor. We are making a plane from the tumor and the brain, ventricular surface. The speed has been made 2x just to accommodate so that you can see. Now the plane has been being made with both hands, following the principles of microsurgery basically. The assistant is holding this scope comfortably. We have to ask every time that whether assistant is comfortable or not, because it's very important to make the assistant comfortable. Otherwise, this outcome will be poor. You can see there is good plane. And we are dissecting the tumor from the surrounding parenchyma, ventricular wall. The excellent visualization. You can control bleeding. You can use CUSA and decompress also, but because I got plane, so I'm separating it very well. So after he has been separated from all around, this curtain used as a hemostat. And now it has been almost separated from all around. The biopsy was, this patient was ependymoma. So it has been now almost separated completely. So now taking it out. You can use the scope to take out bleeding from everywhere, from the atrium and the temporal horn, occipital horn. The bleeding has been, this is choroid plexus. You can see here, thermostat vein, septum, and you can clear out the blood. This is a very important use of advantage of endoscope. Now the hemostasis has been done. You can see this is choroid plexus. This is choroid plexus. And you can see this is the foramen Monro through which CSF is coming. Absolute hemostasis, no bleeding, this thermostat vein. And you can see the size of craniotomy, only fingertip, only 2 centimeters. So now this wound has been closed, bone flap has been replaced back, skin sutures, and no EVD was placed. This is a post-op scan, complete excision has been achieved. This is a specimen, and this is the patient biopsy was ependymoma. Another patient, very large tumor, presented with raised pressure. This is the operative video. Similar principle, separating tumor from the surrounding. This is the opposite side ventricle. The septum is involved. So you can see the opposite ventricle wall. The tumor is slowly you can see the most of tumor has been separated out. This is the remaining part of the septum pellucidum from which the tumor is being separated and being dissected away. You can see excellent visualization by the endoscope, which you can never get with the microscope, probably. The assistant is holding the scope, and the tumor is now being separated from the remaining part of the septum. The biopsy of this patient was also ependymoma. Now the tumor is being removed. You can see this is the choroid plexus of the opposite ventricle. This is foramen Monro of the opposite ventricle. This is thermostat vein. You can see excellent visualization. The atrium blood has been removed. Now this is the foramen Monro of the same side. The blood is being removed from the occipital horn and atrium of the same side. You can see the size of the craniotomy, very small. This is the immediate post-op scan, complete tumor excision. This is follow-up MRI after about a year, no recurrence, no residual tumor. Another patient, a small tumor present in the anterior part. This is the operative video. Same principle. Tumor is being separated from the wall. You can use CUSA to decompress it, but sometimes it produces bleeding. So if I get plain, I prefer to take it in toto by separating from the surrounding structure. There is very good plane. So we are able to separate the tumor following the principles of microneurosurgery. Now almost the whole of the tumor has been separated. A small part is left behind. There is a small vessel supplying the tumor, which started bleeding. So we'll coagulate it. Now the tumor is separated. We are taking it out. Again, this biopsy was ependymoma. This is the specimen. Hemostasis. You can see here, this is choroid plexus. This is foramen Monro. This is aqueduct being seen from here through the foramen. This is choroid plexus. Now we are taking out, removing the blood from the occipital horn as well as trigone. So this is post-op scan, no tumor seen. This is specimen biopsy was ependymoma. This was another patient. You can see large tumor completely removed. The biopsy was pilocytic histiocytoma. Another tumor, small. The biopsy was central neurocytoma. This is the linear. These are my previous cases where you can see here the linear scan, a linear scar. Large tumor presented the raised pressure, complete excision. You can see here small corpus callosum. This is the Sega. Another patient, large tumor, complete removal, biopsy was central neurocytoma. Another patient, raised intracranial pressure, complete excision, biopsy was central neurocytoma. Another large tumor, central. This patient developed transient hemiplegia which improved later on. Biopsy was central neurocytoma. This patient is a child, admitted, worsened, repeat scans showed increase in size of tumor, was operated, same approach, complete excision, biopsy was anaplastic ependymoma, developed recurrence after a year. You can see here, this is the burr hole site. Another patient, large tumor, biopsy was central neurocytoma, almost complete excision. These were the previous cases where EVD were put. Now we have stopped using EVD in every patient. This is calcified tumor, biopsy was ependymoma, you can see here. This very large tumor involving the lateral ventricle and third ventricle also, complete size, biopsy was ependymoma. Another tumor, lateral ventricle, complete size, biopsy was ATRT. This tumor filling almost both the ventricles, completely excised, biopsy was central neurocytoma. Another very large tumor involving the both the lateral ventricles, completely excised. You can see here a small incision, biopsy was ATRT. This very large tumor filling the whole of the lateral ventricle of the left side, occipital horn, everything. The biopsy was pilocytic histiocytoma. Another large tumor, central neurocytoma. Another central neurocytoma. This was anaplastic ependymoma, large tumor involving the lateral ventricle. This patient has small lateral ventricle tumor presented with bleed, completely excised, diffuse histiocytoma. Another large central neurocytoma, completely excised, you can see here. This patient was operated elsewhere. You can see the very large scar and some decompression was done. This was operated by us. Small scar, you can see here, complete excision, biopsy was pilocytic histiocytoma. This very large tumor filling both the lateral ventricles, completely excised, oligodendroglioma. Another Sega, large tumor, completely excised. This tumor presented with was recurrent teratoma, operated 3 times. You can see here the previous scar. This was operated by us, completely excised. This patient has dermoid, same approach, completely excised. This was another patient presented with large lateral ventricle tumor, biopsy was Sega. Another central neurocytoma. Now, tumors which are presented trigone, very large tumor presented with raised pressure. Here the burr hole is made, keyhole craniotomy is made. just superior to the pinna. You can see here small complete size. This is scar about 21 millimeter craniotomy size. Another trigonal mass in atria and trigone. This is the complete excision. You can see here this is scar, biopsy was ependymoma. Another mass, biopsy was ependymoma. You can see here the tract, large meningioma, complete excised. Choroid process papilloma, completely excised. This child presented with very large tumor. I thought we can try with this approach. There was huge bleeding. So initially said to stop. We stopped it. The biopsy was yolk sac tumor. Child presented with again recurrence. Shunt was done and then complete excised. The tumor was excised. Biopsy was yolk sac tumor. This patient presented with huge edema and large mass in the trigone. I thought I can try with this approach. We went in, removed the tumor, but patient, and the end of surgery, the anesthesia plane became light, patient bugged up, there was brain started herniating, some part was removed, there was IVH. So our patient underwent decompressive craniotomy. This is the patient, later on improved. So we have operated about 40 cases. The extent-task excision was total in 37 patients, subtotal in 3 patients. 1 patient needed surgery who developed IVH and operative site edema. 5 patients developed transient hemiplegia but improved later on. Wound bulge was present in 4 cases and there was no mortality. These are the various histopathology of our cases. Most prominent central neurocytoma, followed by ependymoma, polycythoma, and others. The main limitations are the image is 2-dimensional and there is a steep learning curve and the limited, one has to learn to work in a limited working space. So to conclude, endoscopic excision of lateral ventricular tumors is feasible in small and large sized tumors. It is minimally invasive and associated with good surgical outcome. However, learning curve is a limiting factor. Thank you very much for the patient hearing.
Thank you very much, Awadesh. That was really superb. A very, very elegant disposition. Of course, we have to call you a very daring neurosurgeon, definitely, with endoscope. Actually, you have converted the microsurgical technique through the endoscope, which is something really worth sort of weaving.
Thank you, sir.
Yes. Now, may I invite the panelists to start with Dr. Dept, please. Any comments?
Basically, Awadesh, congratulations for I think it was a very good talk. Lot of things to learn from. I am not personally a completely dedicated to pure endoscopic surgery for intraventricular tumors. The way you have overcome this problem is by doing what Pernesky classifies as endoscope guided surgery. And you are following almost all the principles that we do for endonasal surgery. You have somebody holding the microscope. The person holding the microscope is a trained surgeon herself or himself and is guiding you and making your 2-dimensional view into 3-dimensional view. So you have actually a better kind of a exposure than what you can get through endoport. And you can use both your hands with a dynamic kind of vision. I think all these are big advantages and all this has helped you quite a bit. But I have 2 or 3 reservations about your technique. Number one is, in an endoscopic technique, I find it very difficult to understand why do you need to use bayonet instruments. It has absolutely no advantage in using a bayonet instruments, including seizures, bipolars, and everything else. The second thing is why, if you are insisting on using a short corridor, not putting an endoport, why are you not using shaft instruments which are dedicated to this kind of surgery? The third thing is, why are you sharing the white fibers by moving your endoscope all around rather than just dilating the tract with, you can do it, inflate it with a water-filled glove or air-filled glove, and you can do that without sharing all the white fibers going right up to the. And the last point, which I think is very important even for the young people, is why are you against packing of the ventricle? The first thing I would do when I go for an intraventricular tumor is to put patties all around my dissection area, patties all around the tumor, so that I know that with endoscope you can remove blood from various places, but with a rigid endoscope there is a limitation, and not only limitation, when the tumor is already removed and the hydrocephalus has resolved, ventricles sometimes become empty. You have to irrigate it quite a lot to actually make the ventricle dilate enough to pass safely your endoscope in all the corners. Otherwise it shrinks and it becomes very difficult and you can damage the ependyma. So congratulations for all your nice work, but these are my reservations.
Thank you, Rajesh, sir. But actually, I am doing with whatever instruments I have. I will be having it will be a luxury to use all those instruments.
Cheaper than bayonet instruments. Don't
Yes,
worry.
but actually, in the government setup, we have whatever we are. I am doing, and I am quite comfortable with this. So that is the one reason. And the other thing that actually there are so many questions. I forgot many of them, but
Track and tracking, I think, are the only two things I want you to answer.
Yes. Of the white fibers.
Yeah, track. Yes. Earlier, I used to do some amount of cardiectomy, and after that, when I was having this old sheath of the endoscope with me, which is quite large. So once it goes inside, and I just make a small round, maneuver of making what I've shown in my video, and this displaces the fiber. Yes, I never tried. I have heard about this glove in a ventricle needle. So I think I should do it, and I will do in subsequent cases. This is a good idea. But believe me, this also works very well, and this shifts the fibers. It doesn't. I mean, it doesn't shear the fibers. This maneuver with this sheath of the endoscope, which is quite a big bore sheath. So it helps. And moreover, once you use your instrument and endoscope working instrument and suction, they provide you a give a dynamic retraction. So they provide a dynamic retraction and keep the tract patent all the times. And you can move it in the direction of the tract. You can move in any way along with the assistant endoscope as per your need. And the next question, that using a patty over the tumor, yes, I do use cotton patties most of times, but I used to prefer less and use as minimum as possible. That is the way.
Professor Sergey, I think you raised your hand and you wanted to ask something. Can you unmute yourself first, please?
Thank you for the very nice presentation and enormous experience with your method. But I have one general question. So do you use only the endoscopic techniques for the removal of the tumors of the lateral ventricles, or the microsurgery as well? And if so, what are the indications for the endoscopic treatment? For the usage of the endoscopic techniques? Perhaps we can divide the situations where the microsurgery is more preferable, and in other cases where the endoscopy is indicated. What is your opinion?
Before 2015, I was using microscope for these lateral ventricular tumors. But after that, all lateral ventricular tumors I am reviewing with endoscope. And I'm quite happy with that. So no microscope business now.
That's great. That's great. Professor Chhabra, do you have any questions, please?
Congratulations, Awadesh.
Thank you.
It was basically you attempted all kind of tumors through endoscopy, especially in the ventricle area. That is a commendable job you have done. Basically, my question is, you basically attempted all kind of tumors. Is there any relative contraindication from your side?
I don't think there is any contraindication. If hydrocephalus is present, this is the basically prerequisite. If there is no hydrocephalus, then probably it may not be worthwhile, because maneuverability of the instrument will be less.
Okay. My related question is, basically, I mean, in your list, you attempted all kind of tumors. Basically, however, the choroid plexus papilloma, basically, in your list, it was only one. So, I mean, what is your experience with choroid plexus papilloma? Because they are quite vascular, and is there any advantage of reaching the pedicle early? What you do with pedicle or anything else?
I have operated one case of choroid plexus papilloma that was mostly present in the third ventricle, and very small part was coming through the choroid fissure was coming into the lateral ventricle. It was removed very well with this endoscope. There is no problem because with endoscope you can put a patty over the choroid plexus papilloma tumor and then visualize where is the pedicle and just cut the pedicle, take out the tumor. It's very easy. And I'm looking for if I can get any more choroid plexus papilloma in the lateral ventricle, but I didn't get. That is the reason.
It's interesting. I mean, that way. That's why I was asking whether with endoscopy you can reach to pedicle early or.
Yes, I think that is one advantage of. I mean, I use it mainly to coagulate pedicle before I do assisted surgery for choroid plexus papilloma. So it helps quite a bit. It reduces bleeding, and I can't remember any patient having had problems with bleeding inside the ventricles. The other question I wanted to ask, I think Rajesh has asked you very, very specifically. Most of the tumors which you have operated, except for a couple of cases which you have shown towards the end, meningioma, they are all in the somewhere around the foramen of Monro. Are you using it selectively for trigone and atrial tumor, or are you using for all of those as well?
No, as I said, that the hydrocephalus is very important factor for this. Once you see if there is hydrocephalus present, you take your scope to in the ventricular area, see around the tumor, and then if there is vascular pedicle or anything is there, vascular supply, you can take it out, and you can remove the tumor. So hydrocephalus is very mandatory for this.
I would just like to put this to all the panelists for that matter. How comfortable are you with this incision just above the ear, especially if you have a left atrial tumor?
Let me tell you one thing more.
I am not. I go through the parieto-occipital sulcus, so I am there.
Actually, one thing is also important. Many times, in most of my cases, the tumor was the distance between the tumor and the surface was the least just above the pinna. That was also an important consideration.
Can we hear Dr. Professor Rajesh Parihar and give his comment?
Dr. Yadav has a comment in the chat box. Just see.
Sir is asking about soiling of the endoscope, I think, because that is the, if you are not using any port, it is, I think, quite frequently the endoscope gets soiled. So how will you deal with it?
I think I did not tell this thing that I keep on irrigating with the scope with the myself, not the assistant. Assistant job is just to hold the scope. I keep on irrigating it so that it doesn't get soiled.
Okay. In larger
and moreover, intermittent irrigation is also very important, because if you don't irrigate, the surface of the bridging veins may get, sheared off, and there may be subdural hemato formation. So intermittent irrigation is must. Whether endoscope gets soiled or not, it is must.
There's a question from Santosh Takale, who says that as tumor decompressed, cortex will be falling in the field and filling the surgical field and create problems. Is that a problem for you?
Yes, it is a problem, because it is a grave problem, particularly with large tumors. But your endoscope also acts as a detector, and suction and instrument is also as a detector. So they keep on maintain the tract. You have to learn it, basically, this thing.
No. We admire your skills. We admire your skills.
You are using a technique like endonasal surgery to the best possible way for.
Yes, sir.
Right. Okay. If I think we are running short of time, so I now have the pleasure of thank you, Awadesh, for your
Thank you, sir.
pleasure. And now I have the honor to invite Professor Suresh Sankhla, our president, to give his presentation on surgery of the lateral ventricle. So I request Dr. Sankhla to start his talk, please.
Thank you, Ashish, for introduction and invitation. And
I think you don't need an introduction, so I didn't introduce you.
No, that's fine. Whatever briefly you said, that's good enough. Okay. So after the two good talks on the endoscopic removal of the intraventricular tumors, which we heard just now, I thought I will just briefly discuss the other option, which is the endoport option or endoport surgery for removal of the intraventricular tumor, and would like to share my experience with you all. Endoscopic surgery for the intraventricular tumor has been a standard of care nowadays, and it is a very established kind of surgical method for the intraventricular tumors. However, there are some limitations associated with the pure endoscopic approach. And one of the most important limitation is that it doesn't allow the micro neurosurgeon to use both hands. So the bimanual coordination and bimanual dissection that we normally that we are used to remove these tumors is really very limited. And for that purpose, the endoport has been introduced in the surgical management of the intraventricular tumors. And some of these intraventricular tumors, particularly those which are accessible very conveniently, like those tumors which are located in the frontal horn, or in the body, or in the body of this tumor, or body of the third lateral ventricle, or the foramen Monro region, particularly when the foramen Monro is enlarged, then probably we can achieve the endoscopic dissection using endoport very easily. And the same thing is applicable when the tumors are located in the other end of the occipital horn of the lateral ventricle. So now the advantages of endoport surgery is that it allows you to use bimanual dissection. Regular microsurgical instruments can be used rather than using very specific endoscopic instruments, which may or may not be available at all the centers. And then the other advantage is that you can have the underwater surgery with the CSF or water field surgery, as well as the dry field surgery whenever it is required. So these are the endoports commercially available easily. This is the viewport, and this is the new port from Japan, and this is the brain path, which various sizes and shapes are available nowadays. The one which is very popular in India is the one which has been introduced by Professor Y.R. Yadav at Jabalpur, which is basically a collapsible tube which is cut across along this length, and it is foldable on itself. So its diameter can be controlled very easily and can be changed according to the requirement. What we have been using is this plastic collapsible soft atraumatic tube, which can be cut according to your need in the length, and its diameter is about 12 millimeter. And we use the blood collection test tubes, which fit snugly into it and work as a stellate while introducing the tubes into the ventricular system. The diameter is 12 millimeter, which is large enough to have 4 instruments together can be introduced, and you can work easily without interfering with each other. The endoscope, which is 4 millimeter, usually straight 0-degree endoscope or 30-degree endoscope, can be kept at the upper part or upper half of the port, while the suction goes in the left hand and the left side of the port, and the dissecting instrument goes in surgeon's right hand and the right side of the port. And this is the cannula, which is used for irrigation, which can be used on the right or left side as per the requirement. The burr hole is chosen as per the requirement according to the navigation, which we use nowadays routinely, or based on the preoperative imaging on SAG and coronal sections. The length of the tube is also selected according to the requirement and can be pre-planned pre-operatively. A burr hole is drilled as usual in the spot which is be chosen and selected, and the dura is opened widely. The cortex opening is made, and then this tube is introduced along with its blunt and smooth-ended stylate into the required length into the ventricles. Once the ventricle is achieved, you can remove the port, remove the stylate, and then uh, you can split the tube in two halves and can be sutured along the scalp edges on either side so as to fix this tube in position. These are the routine and the regular endoscopic and regular instruments which we use for transsphenoidal surgery. At the end, we either put a plate to cover the burr hole site, or nowadays we use slightly bigger bone flap, and the raised bone flap is relieved back and stabilized or fitted post-operatively at the end of closure. So this is the burr hole, which is anteriorly and medial to the shape of the ventricle. Remember, the ventricle size of the frontal or the frontal horn shape is such that it really reflects on the lateral side. But if you go along the long axis of the ventricle, it goes, the entry point is always, and the trajectory, they are always in the very close to the midline and in a straight line. If you go according to the frontal horn size and shape and direction, then you end up going through this way, which is the wrong way, and you won't be able to see this part of the tumor at all. So another, this is the tumor which is occupying the occipital part, occipital horn, all the body or the trigone. And here you have to choose the burr hole accordingly along the long axis of the ventricle body as well as the long axis of the tumor. The trajectory is always the long axis of the tumor, and that you can determine on the based of the preoperative investigations or imaging. Fluid irrigation is a must to keep the ventricular cavity dilated. Once the ventricular cavity is collapsed, it becomes very difficult to not only to introduce this, but to keep it there in order to do the tumor dissection. The third ventricle tumor can also be accessed using this approach if the lateral ventricle and the foramen Monro is particularly is large. Like in this case, this is the choroid cyst, a large choroid cyst, and you can see the size of the foramen Monro, which is big enough to really introduce this 11 or 12 millimeter tube very close to the foramen Monro and into the third ventricle, anterior part of the third ventricle. So these are the indications which we follow for the neuroport surgery for intraventricular tumor. The lateral ventricle should be dilated and should be a like big cavity in which all the instruments and the port can be introduced. The tumors are usually small or the medium size, because the larger tumors which are extending into the various parts of the lateral ventricle are very difficult to really access and remove. The tumors located in the frontal horn, the body and occipital horns are the ideal tumor to use this technique. Tumors with lesser vascularity are preferable because even if you are able to use the bipolar and other techniques to make the hemostasis, still it is very difficult to really have a very profusely vascular tumor removed using this technique. And you can achieve biopsy, you can achieve the tumor decompression, and you can achieve total of the tumor. Third ventricular tumors, the indications when the lateral ventricle is dilated and the foramen Monro is also dilated enough to be able to have the 11 millimeter or 12 millimeter tube inserted through it. The tumor located in the anterior part of the third ventricle are easily approachable using this technique, and tumors with less vascularity and you can achieve biopsy, decompression, and cyst aspiration very safely and very effectively using this training. And I'm going to show some example of cases that we have used this technique in. So this is a 24-year-old lady who presented with headaches and signs of raised intracranial pressure, and there was a big large tumor located in the left lateral ventricle as well as right lateral ventricle. And before coming to our hospital, this patient had undergone surgery through the right frontal craniotomy and some part of the tumor was removed, but a substantial amount of the tumor was left alone, enough to cause ventricular dilatation and symptoms of raised intracranial pressure. So we thought we will approach this tumor from the left side using the left frontal burr hole and the left lateral ventricle. So this is the port, which is transparent, and it has been introduced into the lateral ventricle frontal horn, and this is the edge of the port, and at the end of this after CSF drainage, you can see the grayish color, very distinguished tumor seen quite well. The tumor was luckily less vascular and could easily be separated from the surrounding ependymal lining, and was decompressed using the piecemeal technique. We used once or twice micro scissors also to cut this tumor into pieces, because it was at places quite firm in consistency and not purely suckable tumor. But as you mobilize the tumor all around, we realized that this tumor is not adherent very seriously to the ventricular cavity, and was possible to dissect it away from the ventricular cavity. And then in the end, the tumor was pulled out gently, and complete tumor removal was achieved. We were planning to do the other procedure or leaving the drain, but we felt in the end that it is not required. And this is how we approached it, through the left lateral ventricle, frontal horn, and this is the total excision of this tumor. This is the trajectory that we used using the endoport. Another patient, 21-year-old female, who presented with seizures, followed by headache, drowsiness, and other symptoms of raised intracranial pressure. And there was a tumor in more or less similar location, except that this tumor was not entirely within the lateral ventricle, and it is really part of it was coming outside in the parenchyma, which was a little bit of concern, but we thought we will try with the endoport technique. So in the similar way, we put the burr hole in the left frontal region, and this is the endoport, which is transparent. You can see the normal brain parenchyma through it, and this is the ventricle which has been punctured. The CSF egress was seen, and then the tumor was approached. The tumor was very poorly distinguishable, but as we went into the depth, we realized that the tumor is grayish in color, and it was quite possible to decompress the tumor and then mobilize the tumor capsule or the pseudo capsule. And in the end, this is the central part and the part of the tumor which was going outside the ventricle into the parenchyma. But luckily, it was easy to distinguish and to separate it from the parenchyma, and removed it using the similar technique. So this is towards the end. You can see the tumor cavity very well. The CSF flow in the ventricle is seen quite well. And here also, we did not feel the need of putting any drain or any post-operatively into the ventricular cavity. And these are the post-operative scans showing complete resection of the tumor. Even the tumor which was extending into the parenchyma was, this portion was also removed. And this is the burr hole, and this is the trajectory that we used. This turned out to be a pilocytic astrocytoma, and total resection was achieved. The patient is in follow-up without any recurrence. This is another patient, 64-year-old male, presented with headaches and slow dementia. And the MR scan revealed a variegated appearance in homogeneous contrast enhancing lesion in the body of the right lateral ventricle with expanded lateral occipital horn of the right lateral ventricle. We use the navigation technique to decide the trajectory in this patient, and this is how we approach this tumor. Again, this is the port, which is seen quite well here. And then when we reach the ventricular cavity, we found CSF coming out quite well. And then it was a rather firm tumor against our expectation, and it was very rubbery in consistency, very difficult to really mobilize it or very difficult to suck it out. But yes, piecemeal excision was performed using the internal decompression first. At places there were white patches or firm areas of the tumor which was seen quite well, and this is towards the end of the tumor. You can see the ventricular cavity on the other side of the tumor capsule. This is all the tumor which was removed, and this is the portion of the tumor which is in the end removed completely, and hemostasis was achieved using the normal coagulation technique, and then the good CSF flow towards the end. These are the post-operative scan. This is the trajectory and the path through which we really approach the right occipital horn. This is the approach. And this was a high-grade tumor, required adjunctive treatment post-operatively. Another patient, a 40-year-old female, presented with headache, nausea, vomiting, and papilledema. And the MR scan revealed a small colloid cyst with large ventricles. And we approach this cyst also in the same way. So this is the septal vein, and this is the foramen Monro. And as soon as we reach there, unfortunately, the foramen Monro was small enough, and our port was much bigger. We couldn't go there, and we punctured the cyst and tried to remove the contents slowly. And similarly here, the contents were aspirated, and in the end, a total removal, this is the foramen Monro, total removal of the colloid cyst was achieved. And these are the post-operative, immediate post-operative scans showing complete removal, and this is the trajectory. Another patient who had a large colloid cyst, unilateral, more or less on one side, but blocking or obstructing both the foramen Monro. Although the right-sided foramen Monro was very big, big enough to really approach there, and this is the outlines of the cyst on the preoperative MRI scan. So we tried this colloid cyst also using this approach, and this is the part of the colloid cyst which was coming out in the lateral ventricle. We punctured it and we tried to remove the contents and mobilize the cyst wall, but it was not possible to remove entirely. The foramen Monro was ill-defined, and you could still see this part of the cyst wall, which was very difficult and unsafe to dissect from the ventricular wall. So we did not try to remove it further. And these are the post-operative scans showing a residual capsule area here, residual capsule, but the ventricular size has really come down completely. Both the foramen Monro have opened up, hydrocephalus has resolved completely, and this patient is kept on continuous follow-up post-operatively and is still doing very well. Another patient, a large one, this patient we tried from the right lateral ventricle frontal horn, and this is how we approached it, and this is the end of the tumor removal. We had to leave some part of the tumor because of the poor visibility in the ends and some vascularity, which was our main concern. So the most posterior part of the tumor was left alone, and this was an ependymoma, and the patient is on follow-up. Another patient which was in the occipital horn, the ventricular size was very small, but we thought using the stereotactic navigation technique, we should be able to approach it, and this is how we approached it. It turned out to be a glioblastoma. We managed to remove it, quite a bit of it, and subjected him to the radiation therapy post-operatively. So there were altogether 15 patients in the last two and a half years' time. 11 of them were located in the lateral ventricle. 2 were in the foramen Monro region, and 2 in the anterior third ventricle. Most of these tumors were benign, mainly the central neurocytoma and low-grade astrocytoma, pilocytic astrocytoma, ependymomas. But 1 or 2 patient had a malignant or high-grade astrocytoma and gliomas. Out of these 11 patients, more than 50% of the patient had gross total resection of their tumor. We also did septectomy in 4 patients, and the VP shunt was done in 3 of these patients. Out of the third ventricular tumors, two were colloid cysts, one was glioma, and one was a recurrent glioma, in which only the decompression was possible. This patient was an elderly male who only required biopsy. Uh, and then these two patient colloid cysts, which was resected, one of them was resected completely, another was incompletely removed and under observation now. We had a fair bit of complications as well, and we observed that the intraoperative complication is mainly because of the incomplete removal, because of inaccessible tumor extensions, or firm tumor consistency, or unclear visualization of the tumor margins, or bleeding at times, and all of them had incomplete tumor removal. Post-operatively, we had hydrocephalus in all these patients, but only 4 patients required VP shunt post-operatively. Two patients had seizures, 3 patients had transient hemiparesis, and 2 patients had memory impairment. One of them improved completely post-operatively. So in conclusion, I would like to say that the endoport surgery is a safe and effective method for sampling and complete removal of small and medium-sized intraventricular tumors, with not much increase in the procedure-related complications. Now, with the gaining more experience with this method, we are now approaching larger tumors in the recent times. The technique is also very effective in restoration of the CSF pathways, and only 4 patients required VP shunt in our series. Factors that influence the complete endoscopic tumor resections include tumor size, consistency of the tumor, and vascularity. These are the main factors of influencing the tumor resectability. Careful patient selection and preoperative planning is essential for better surgical outcome. And we think that the newer intraoperative adjuncts like neuronavigation, ultrasonic aspirators, and fluorescent contrast agents, laser, may be very helpful to improve the surgical outcome in these patients. And I thank you very much for your kind attention. Ashish, back to you.
Yeah, thank you, Dr. Sankhla, for this excellent talk. Just a couple of thoughts in my mind. When you're doing an incomplete excision, are you putting an external ventricular drain just to see that blood and everything comes out? Because that's number one. And secondly, you're working through an endoport. If there's blood trickling down in the other areas of the ventricle, what are the measures that you take to prevent that?
Yeah, first bleeding. Inadequate visualization because of bleeding was seen in just 2 of the patients. In one of them, we were managed to see the tumor cavity completely and the tumor margins complete, and we managed to remove it completely. In other patient, we had to really leave some part of the tumor without making any further attempt to remove it because of the vascularity. As far as the bleeding going into the other part is concerned, we keep the irrigation at a very, very high rate. Okay? So the suction and irrigation becomes the main part of the surgical technique. And every part of the hemorrhage is sucked away immediately. However, in the end, we try and manage to see the other parts of the ventricular cavity, for example, occipital horn and third ventricle part, to see if there's any blood clot there. If it is there and suckable, we can remove it. But I agree, all parts of the ventricular cavity is not visualized using this method, and you have to be very careful when there is bleeding in the tumor.
Thank you. Can I request Dr. Vijay Parihar, who is working with Dr. Yadav? They are using this endoport system, and what is his experience on this?
Yeah, sir. We are using the silicon foldable tube, as sir has already mentioned in slides, and that is really very helpful to us. It is not only give a equidistance retraction to the brain, avoid the brain injury as we use the fixed retractor, and also it is transparent, so you can continuously visualizing the normal brain parenchyma, and also prevent the swelling of the scope also. So I think it's a very good use.
Vijay, you use a tract, you form the tract first to introduce.
We form the tract first, and then we use the nasal speculum to dilate that tract, and then we insert the that foldable tube through that tract.
Yeah, that's great technique too. Agree with you.
I think.
How do you, Vijay? Sorry, how do you, control the bleeding going into the other parts of the ventricle if you are doing the intraventricular tumor surgery using this port?
Sir, we just using the patties also, especially the surrounding the brain area. And after the end of the resection, we inspect with the endoscope and try to take out blood by the suction as well as by the irrigation. And if any doubt, we don't hesitate to put the external ventricular drain post-operatively for a few days.
Right. Professor Chhabra has had to leave because of some urgent case in the operation theatre. So may I request Professor Dev Pujari for any comments or questions?
I think Ashish he has to go.
Professor Sergey would like to speak something.
Yeah.
Sure. Sergey.
Thank you for an excellent report. It is very dedicated. But I have one question. Are there any situations where you have to convert your surgery into the open one, into the microscopic one? And if it is possible to convert in any situations, for example, in the extensive bleeding or the tumor size or something else?
Yes, it is possible. So far, luckily, we have not encountered any situation where we had to convert this thing from endoscopic to microscopic. But then, if it is required, you can do it. And I feel that in that colloid cyst case, which we had to leave some part of it, that was the right case. We should have removed the endoport and used the microscope to remove it completely. That mistake we made. But yes, there are some situations. Similarly, in highly vascular tumors, if you find that it is difficult to manage using the endoport, you can just remove it and introduce your microscope. It's a very useful technique, and thank you for the suggestion.
Right. If that's the end of the webinar for today, I thank all the speakers. I just want to make a little bit of controversial comment at the end. The idea that the endoport gives a uniform retraction is not absolutely correct. We go through the literature. There are various papers which say the extent of retraction you can do with a very tiny retractor, and in the pressure gradients are created, so that to say that only by the tubular retractor you are giving the safest approach to the brain is not always 100% true. Rather, there are papers which say that there might be little harm if you're going through various intricate areas of the brain. So with that note, I thank all the speakers. It's an excellent sort of webinar where the speakers really demonstrated excellent skills, and this is something going to be the future approach to tumors in this region. I'm very sure about it, and we'll learn more and more as more equipments and newer devices come to light. With this, I hand over again the mic to Mr. Naik to give a concluding remark.
Yeah, thank you very much, sir. I think it was an excellent webinar with real techniques shown. When experts showcase their skills and talent, followers follow in plenty. So we had 233 doctors who logged in, neurosurgeons from 4 different countries, and 14 logins have come from abroad. So I would like to thank our international speaker, Professor Sergey, for his excellent presentation, followed by Professor Awadesh, Kumar, Jaiswal, and our own Dr. Suresh Sankhla, who conceptualized this webinar series, aptly supported by, with a great value addition by Professor Dev Pujari sir, who has always been supporting us in all our webinars, Professor Rajesh Chhabra, and Professor Vijay Parihar. Thank you very much, Professor Ashish Pathak, for putting this together, this webinar. And I'm sure our audience must have benefited a lot, especially the young neurosurgeons must have benefited from the techniques, skills, do's and don'ts that are given by our experts. On behalf of Health and You, we always, yes, sir, you wanted to say something?
I just want to make an announcement. The next webinar is on 13th of December, Sunday, and the topics are going to be endoscopic challenges in endoscopic removal of invasive and giant pituitary tumors. And the other one is tricks in endoscopic removal of suprasellar lesion, probably through the nose. So be ready to again join us, please.
Great.
Thank you.
Thank you for the announcement. And this is Deepak Naik on behalf of Health and You. Would like to thank all the speakers, the panelists, and audience who joined us, taking time out of their busy schedule. Continue to support Health and You, and please look at Digi Neuro channel available on YouTube. This webinar will be available tomorrow. Till then, till we meet next. Goodbye and good night to all of you. Thank you very much.
Thank you, Mr. Naik. Thanks.
Thanks.
Serge.
Thank you, sir.
Okay.